Well, so 12 guys up in the north golfing for 4 days. That's so I take it did start on Thursday then? Thursday, Friday, Saturday, Sunday for you?
Wednesday. We left Wednesday
Okay.
morning, went up to the UP, and played Wednesday, Thursday, Friday, Saturday.
Amazing.
So
I couldn't tell you the last time I played 18 holes of golf, let alone 4 days in a row of 18. If you're a big golf enthusiast, that sounds like the dream. I enjoy one round of golf for a bachelor party or a birthday or Father's Day or something like every year. I hit, one ridiculous good shot per round, and that's it. That's it. That's what I get out of it. That's for me. It's like I had a good round. If I hit one good shot, doesn't even have to go in, just has to get close. That's kind of how I view my round of golf. But
yeah,
I enjoy it. It's fun. It's a social thing. It's getting out there with the boys
sure.
and just smack talking. And also,
Hmm.
the thing I like about golf, and this is kind of, similar to business, at least how I view it, is you can recognize when someone else brought their A game to the course. When someone else is like locked in and they're just nailing shots left and right. You're like, man, crack on. Like, good for you. This is pretty cool to watch. I wish I could do it. I wish I could do it like you. But same with business though, because it, it's it, it's not a zero sum game. If someone else is succeeding, that doesn't mean that they're taking it away from me. It's just like you control your shot. Like you have to make sure that you're adequately prepped. You got the right equipment, and if someone else is doing a really really decent job, like just tip your hat to them and just say like, hey, keep it up, man. You're setting the bar high, setting the standards high, and that's something to aspire to work towards. Not like in soccer when there's a team of 11, the goalkeeper always gets blamed if they get scored on, but it's like the ball went past 10 other people, like you're just one component of the game, right? Like if you really blow it one day, then yeah, like it's kind of your fault, but the ball still has to get past 10 other players. So it's a little bit more of a, mid-level, mid-sized company that's just got a lot of moving parts and a lot of different people. So that's today's not really a business call. Today's more of a clinical call, but I can't help but see the parallels in sport and in business. So, and any highlights besides the golf? Any highlights that you want to share in the last 7 days? I guess maybe 2 weeks since we missed you last week.
Uh, 2 weeks. I mean, I guess I guess running up to going on vacation, it just takes a lot of work in order to get out of the office for that
Mm-hmm.
amount of time. So it was just kind of really, putting my head down and focusing on completing the tasks that I needed to get done in order to just take, 3 days of the work month off. So it was, and then coming back, was managing, things. And so I feel like I handled that pretty well. So I guess that was, that's, a takeaway
Yeah.
from this past week, just putting in the legwork, being, laser focused and in order to take some time off and then come back and hit the ground running.
Yeah. Yeah. I think what do they say? The most productive days of someone's work year are the 2 or 3 days leading up to a vacation, right? It's just like because you don't want to come back to a mountain of work, so you want to get as much done as possible. Makes no sense, right? Makes no sense at all. But this is just the human psyche and just the human behavior aspect of it. And yeah, I mean that's you walked right into that one to get some stuff done, and things build up, don't they? Like call it the environment, the world, the society, your patients, whatever. As soon as you either announce or you just decide I'm going to take Wednesday, Thursday, Friday off, it's like things just start hitting the fan. People start calling you up and they don't normally call you up needing things from you. And you're like, of all the weeks, this is the week that you decide to I've been trying to get in touch with you, Mrs. Smith, for 6 months. No, just crickets, no response from you whatsoever. But now all of a sudden this week, it's like I will see you on Monday or maybe Tuesday, or you know what, maybe Thursday. Maybe I'll see you in over a week, but anyways, maybe that's just me, or maybe that hits pretty close to home. I don't know. But okay. So the thought occurred to me to kind of cycle in some clinical, components to these mentorship, to these, yeah, cohort type calls, because I do enjoy the clinical aspect. I don't want this to just be business sales, hiring, firing, that sort of thing. I do really enjoy the clinical side. It's really fulfilling to work on patients one-on-one, but then also to educate those around me in my sphere of influence, like I've mentioned before. And that just so happens to be, in this case, you, Josh. It could be other people in the mastermind group, and it could be people that took advantage of my birthday offer and are getting to watch the replay of this. So we've got 53 people. 53 people purchased my birthday offer. And so they get the replay links. I'm sure they'll hop on. They don't know yet that they can hop on and watch this live, and that's okay. Like, we're just going to keep going. I've got a list of questions that we're going to go through that are kind of frequently asked questions when it comes to the concept of blood flow restriction. Have you heard of BFR? Have you done a BFR course, Josh? What's your background with BFR?
I took the dry needling course. We kind of covered it a little bit in there, and just looking at the 4-week, that recovery of that guy's quad was just pretty amazing. And you know, it's my wife's into bodybuilding, and so like I showed her some of that, you know, like over that period of time, and she was just like, wow, that's possible. This,
Mm-hmm.
you know, she heard of it, but like hadn't seen examples of it. And so that's kind of my experience with it, but it is a very interesting concept.
Yeah, so and I do share that at every needling class, because we are affecting skeletal muscle and the peripheral and central nervous system by needling. But that's only one component. Obviously the multiple stages of treatment, in my opinion, include loading that tissue. Like, one of the biggest things that I see when people reach out to me for problematic cases, and I just do it. Like, I don't charge people. I'm just like, I love looking into the lens in which clinicians are evaluating and then their treatment. And an overwhelmingly common theme in chiropractic offices, even in 2023, is the fear of loading the tissue. There's a avoidance of progressing a patient through loading strategies. There's all sorts of treatment with all the letters after their names, all the soft tissue, this and that, and laser and all that is good and fine when it comes to what I just kind of refer to as stage 1 care, which is like pain and mobility, right? Like, pain and mobility, that's where we're getting all of the soft tissue remedies and dry needling, all of that stuff. That's pain and mobility. But how do we actually create a sustained change to the skeletal muscle? Like, you either inject it, right, with some type of steroid, and that's not possible for a lot of our patients. Although maybe your wife knows people that that get into, that dabble in the dark arts of injections, but that's not an option for an overwhelming majority, or 90% of us. So what do? Well, we just have to freaking load it. And so what does that look like? There are certain ways that you can enter into progressive loading strategies. And for me, that just so happens to be BFR. BFR is blood flow restriction. It is where you put a tourniquet on an arm or on a leg, and those are the only two places. I'll talk about safety in a minute here, but there is a pelvic tourniquet that is to save your life in the event that there is some type of bleed out or aneurysm, or there's some life-saving procedure needs to be done, and you put a tourniquet on your waist and basically tourniquet the aorta with a pelvic tourniquet. But that, we don't exercise with that. Like, that's not what we're using. We use the arm cuff and the leg cuff. It's got a downstream effect. So if you have tennis elbow, you still put it high on the arm, and it affects blood flow all the way down into the digits. And in the leg, you block off at the thigh, the highest proximal component of the thigh, and it blocks or restricts blood flowing down into the lower limb. That's it. Those are the only two spots. we could go, I could probably talk for like 6 hours on this, but I will say that safety wise, those are the two spots. I don't know if you've seen a few years ago, but there was a gymnast that was working through a bit of a calf strain, and she put and I'm just going to name companies. Like I'm just, it's our world, right? Like we're not bad mouthing anyone. Like I think it's helpful to not be vague, but to just, call a spade a spade. So she put an occlusion cuff, which is a company. And I think you can get them for like less than $100. They're very, very cheap. And she put occlusion cuffs on her, just below her knee, kind of wrapping around her patellar tendon below the kneecap, but it goes all the way around. And she started to rep out some calf, almost like calf raises, like heel raises, and to stress strain her calf. And she actually compressed the superficial fibular nerve and developed a temporary foot drop as a result. So that's not good. Just as a word about safety, a lot of times people are worried about blood clotting when it comes to BFR. And it is actually the exact opposite of clotting. And there's a whole pathophysiological explanation for that. That involves, some enzymes and some breakdown of, hydrogen ions and all that stuff, which the course, if you go through a course, they explain all of that. But there have been 0 cases of any type of clotting in a BFR session. There have been other injuries that have occurred. But the number one concern, and any surgeon that understands the concept will not have a worry about any type of clotting, but they will have a serious concern about ischemia of peripheral nerves, which is the case that I just explained to you in regards to the compression of the superficial fibular nerve. So that cuff, just putting tight ischemic pressure onto a peripheral nerve. Peripheral nerves don't really appreciate sustained bouts of localized, that's a key word there, localized pressure. Higher up in the thigh, you've got more adipose tissue, you've got more muscle, and so the nerves get less of isolated pressure because there's just more soft tissue. Down in the leg, a little bit of pressure goes a long way on a peripheral nerve. So to be safe, we always keep the pressure up high in the thigh. So the biggest concern, again, is actually in developing some type of nerve-related injury as a response to either the incorrect cuff size, incorrect pressure. So like you have to know how much pressure to put in someone's limb, or incorrect placement. Like it should be high in the thigh, and for whatever reason it trickled down to mid thigh or low thigh. Like it shouldn't be down there at all. It should be as high up in the thigh, as awkwardly high in the thigh as possible, without touching any goods. I kind of joke around in the clinic. So anyways, that's kind of safety. Like that, those are the two spots that you really do need to know about. Some other questions. So safety was a main question that people, because I put this out on social media, like what questions you want, and safety comes up. Clinical applications is another one. But like what actually happens, right? And so how is it beneficial? And so I think that'll be kind of the next question that I go after, is kind of what's happening when we put a tourniquet on, for example, an arm. So for those of you that don't know, I don't want to insult anyone. I'm going to assume that a lot of people are familiar with maybe the phrase blood flow restriction. But even if you break down what it is a restricted device. So in this case, imagine taking a blood pressure cuff and putting it on your arm as high as it can go, inflating it, and having a microprocessor keep track of how much pressure is going from the device over into the arm to either restrict or completely occlude the arterial and the venous, the arteries and the veins in the area. Now, what's interesting is veins, if I take you all the way back to your histology, veins have a thinner cell wall. So they're a lot more tortuous, right? So that's why we get venous varicose veins, and we get, valves within veins that are activated with muscle contraction. They can't contract like on their own. So veins actually quickly can become occluded. And that is important here because it takes less pressure to occlude a vein than it does an artery. And we're okay with that, which is why if you've ever seen someone go through a BFR session, they actually start to swell up inside the limb that they are working with. And that's because we've got anywhere from 50 to anywhere from 50 to 20%, not a lot, but 20 to 50% blood flowing into the working limb and zero returning because the vein is closed. So that's why it just starts to build up. Now it's not going to like explode like a balloon, but you'll notice some people, they swell up pretty remarkably within even just a 5-minute bout of BFR. Now, it is really important to know what happens the second we get a restriction of blood flowing into a working limb. So let's say I'm sitting here, I've got a rotator cuff. We're going to talk about, even though the rotator cuff is proximal to the cuff, we're going to talk about that in a second. But let's say I've got my cuff here and I'm repping out just my shoulder abductions. Okay. Now that's, in my opinion, that's range of motion. Like we should be able to do that regularly, but for whatever reason, let's say I want to amplify, the patient is talking, it's pretty easy for them to, to get this exercise done, and you're looking to advance it a little bit, progress them on. So we put a tourniquet on their arm. They start exercising, okay? And immediately you'll notice that they stop talking because now we're using oxygen within the skeletal muscle. We're not using oxygen to just talk. So they will notice right away that it is significantly harder, but there's no weight added. The only resistance is due to how heavy the arm feels because we're slowly accumulating lactate and a hydrogen ion. And so the restriction creates these hydrogen ions that stimulate muscle protein synthesis. And that is important because imagine when you're a kid riding your bike up a hill and all of a sudden your legs just got so heavy, right? Like I recently ran up my driveway, which is on a little bit of an incline. And I'm like, man, we live on a ridge. I didn't think that it was that steep. And just 1 or 2 runs for my workout, running up the hill, my legs felt heavy, like I was riding a bike again up a hill as a kid. And that's the buildup of lactate and hydrogen ion. And that feeling is very common, and it is desired during normal bouts of blood flow restriction. So that is really important because that hydrogen ion, it takes us from, and again, I'm going to take you all the way back to your biochemistry, right? That takes us from the Krebs cycle, where we're using oxygen freely as a form of energy creation and transfer. Maybe not creation, but transfer. And that switches us from the aerobic side to the anaerobic side. And I would venture a guess that if I came into, maybe not your clinic, Josh, but if I came into a bunch of your clinics, you guys are doing a lot of aerobic rehabilitation. We are not challenging our patients nearly enough because we're not switching over into that muscle protein synthesis pathway because they're able to use oxygen throughout. Now, don't get me wrong. I'm not saying they need to go full-blown CrossFit and just, do burpees and get sweaty. And that's not what I'm saying. But I think the pendulum has swung so far the other way, where patients are accustomed to coming in, laying on a table, doing some band work, and we're telling them that that's strengthening their rotator cuff. And my argument now is kind of bullish. I'm coming out kind of strongly here by saying I don't think that that's strengthening. If someone has a pink band or a pink dumbbell and they're doing their Y's, T's, W's, they're doing their rotator cuff, that is glorified range of motion. That is not, you cannot call that strengthening. If they are talking, if they are using the same dumbbells week in and week out, they've adapted to that a long time ago. We cannot say that we are strengthening the rotator cuff. Like, sorry. And I'm willing to get some pushback on that. But I want some stressed out limbs. I want people to be safe, right? I'm not trying to be irresponsible or reckless, but I want them to experience what it's like to feel their limb or their arm, in this case, their arm to be stressed out. Because the moment their arm gets stressed out, the moment I know that we've just worked into the muscle protein synthesis pathway, and therefore good things are about to happen. That muscle is going to recover, that tendon's going to be stressed and then adapted. And so in my opinion, we almost need to get our patients out of like passive range of motion, and we need to get them into, what a lot of people are referring to now as beast mode. We need to get them into beast mode. Don't care if it's grandma in her 80s or it's, Emily, the soccer player in college who's just got knee pain, but you look at her quad right to left and the affected leg looks significantly atrophic compared to the other leg. We need to get that leg back into beast mode. We need to get these legs a little bit more symmetrical, especially if it's her, good or dominant leg. So that's kind of the reason why we want to get into beast mode is we change that muscle protein synthesis, but the limb has to be stressed out. So that's kind of like principle number one is good things happen when we're stressed out. And so that's kind of to answer what happens from a biochemical pathophysiological way. That's in a nutshell. That's probably like 3 to 4 hours of the class right there. And then from there, we can kind of get into clinical applications. But I got a couple of people texting me here just about, specific questions. But anything that I've gone over thus far that you have a question or anything about?
No, not yet. Makes sense, so far.
Okay.
Whereas,
No, I should say my training and my background is in the Owens Recovery Sciences curriculum. So I'm a student of Johnny Owens and his curriculum, and then also he has a partnership with Delphi, which I believe is the gold standard, the highest quality tourniquet device. It is one of this is actually a good segue into the next question I had, which is are all BFR devices equal? Can't I just go get, if compression, if what you're saying is good, like, can I just go get some mattress straps off Amazon for $20? Can I just tie it around my biceps and go to the gym and start doing preacher curls? You could do that. But here's one main component of BFR that I've learned over the years is that BFR needs to have a personalized tourniquet pressure. A personalized tourniquet pressure. So mattress straps, it's not personalized. You don't know how many millimeters of mercury you're putting into your right arm, and like cranking it down to just build up, some pressure. And you don't know if it's the same or equal on the other side. You don't know if you're the one putting pressure on. You don't know if you're putting too much, if it's, like if it's I hate to say it, if it's like a fatty limb, or if it's like a pleasantly plump limb, or if it's a little petite limb. You don't know how much pressure you're putting on with a mattress strap. So the pressure does matter. There are other devices out there that aren't even shaped like human anatomy. So I don't know if you guys know this, but our limbs are not perfectly circular, right? We actually have less density in like the mid belly, and then there's a little bit of a cutoff right here, and then it actually gets quite round higher up. And same with the thigh. It's actually much thicker proximal in the thigh than it is down towards the mid thigh, and definitely down by the low thigh. So we actually need to have like a slightly, not that much, if you can see my hands. It's got to be slightly narrower the more distal it goes, because that is that contours with human anatomy. So some of these that are like perfectly straight up and down, that means you're going to be getting a skewed pressure because it's going to be an asymmetrical distribution. The other thing is the size of the cuff absolutely matters. There are some out there that have 1 inch. There's some that are very, very small, very thin. And there's a really good researcher, has actually been on our podcast, the Clinical Leadership Podcast. Here's a shameless plug. If you haven't listened to Jeremy Lenicky and Emily Frith, we interviewed them. I think it was over a year ago we interviewed them, and we discussed some of their papers when it comes to BFR and the size tourniquet. Does the size or the width of the tourniquet matter? And so Jeremy Lineke's out of University of Ole Miss. He's got, he's got some wonderful paper showing that and this just makes physics, like this makes sense from a physics standpoint. If I take a shoelace and I tie it around your arm, the amount of pressure that it takes for that one spot for me to occlude, and I use that word on purpose, for me to occlude the blood flowing from above the tourniquet to below, the amount of pressure is actually quite high, right? In the arm, they've seen measurements above 330 to 350 millimeters of mercury, which is a lot. In the leg, they've seen close to 450 millimeters of mercury of a pressure just by using a very, very thin, like nylon string or something. And that's how you start to damage some peripheral nerves. So we don't want to do that. So the width of the cuff does matter. So some of the other ones that are like 2 inches, you have to have a higher pressure gradient to restrict and occlude the blood flow. So again, I'm an advocate, an ambassador, whatever you want to call it, for the Delphi device, because the Delphi tourniquet system is about 4.5 inches for the arm, and it's about 5.5 to 6 inches for the leg. So imagine you have this 6-inch cuff that is putting pressure on the limb, and you have way more surface area. So therefore, it is much less pressure being exerted onto the limb to get the same effect. And the key there is the lowest or the minimal effect necessary to restrict blood flow, not the maximum, like with a nylon string or a shoelace. We don't want the maximum. That's getting into a dangerous situation for the peripheral nerves. So we want a minimal pressure exposure, and we do that by having a nice wide cuff. So that's about the cuff. And so there are 2 FDA-listed tourniquet systems on the market right now. One is called Smart Cuffs, and one is called the Delphi device, which you have to buy the Smart Cuffs one if you've gone through a Smart Cuffs course. You have to buy a Delphi one. Because they're FDA listed, you have to show that you are a licensed healthcare provider. You can't just call them up and buy it, because it is registered. So if anything happens, they can track back that specific device to the proper owner or the proper, not technician, or just, the user, the proper user. That's how the government works, right? So my advice is look into both. You will see pros and cons to the smart cuffs, and you will see definitely a price difference. I don't even know how much the smart cuffs 2.0 or 3.0, I don't even know how much they're going for right now. My personal view is I'm going to stay away from the smart cuffs. If you want to, I can explain why I think that it's wise to stay away from the smart cuffs at the moment. But I am going to stick with the Delphi. I am a very loyal customer to the Owens Recovery Sciences for really spearheading this blood flow restriction out into the private sector, or at least into the consumer market for us out in private practice. So the Delphi device for me, it also gives me a little peace of mind, because I did ask this question, and I have talked to some surgeons in my area, and I've even brought my Delphi device to their office to show them that, A, I know what I'm talking about, but then B, I'm using a similar device. It's not the same, surgical caliber tourniquet system that they're using in their operating room, but they're going to recognize the company. Delphi is the #1 surgical tourniquet system that's used in operating rooms across the country. So if I walked in with a smart cuff, they wouldn't be familiar with that. But the fact that I walk in with a Delphi, they immediately trust that I am buying high quality, because they know how much their surgical operating or their surgical tourniquet systems cost for the operating room. And it's not the $5,000 I paid for the Delphi one. It's $20,000, $30,000, $50,000 for some of these extensive operating room tourniquet systems. So there's a association by brand that helps build my credibility. Okay. The other thing is when you show a smart cuff, this is the fact, right? I'm going to leave my emotion out of it. When you show an orthopedic surgeon the smart cuff, which I have, they almost they're very weary of using that as a surgical device, because the way that both devices are registered through the FDA, they're under the surgical procedures, part of the FDA. So said differently, the way that smart cuffs got to be an FDA listed device is that they registered the device as a surgical device. I don't know about you, but I don't feel comfortable putting a patient when I'm not using the smart cuff, and I don't know a single surgeon that would use the smart cuff in an operating room. And so that was kind of it was a red flag for me on, is this device as legit as it says it is on paper? And I don't think the answer is yes. So I won't use it. And I know Nick at Smart Tools. I've known him for a long time, and I love what he's done with Smart Tools across the country. I've got no beef with him, no beef with Smart Tools at all. This is just I'm passionate about BFR, and I've got a few concerns about smart cuffs when it comes to their claims and how they've obtained FDA listed status. But that's neither here nor there. There's several other companies that are out there. You definitely get what you pay for. There are multiple occlusion therapy or occlusion cuff type products out there that you have to measure, you have to measure the dorsal pedis. You have to measure the millimeters of mercury in the foot, because you need to make sure that there's actually blood flowing, whether or not the tourniquet system is saying it or not. What I mean by that is sometimes there's two parts. Sometimes there's a handheld part, you got to pump it up, and then you also have to check, to see if there's a pulse in the foot. To me, that takes too long, and it just it's inconvenient to be worrying about what one area of the body's looking like and then have to worry about the foot. So that's just me though. Maybe I'm high maintenance, but no. So you do get what you pay for. So the more bells and whistles, the more automations, the more microprocessing that is in the cuff and that is in the computer chip, the higher the price point is going to be for the tourniquet system you're looking for. So do you guys have a system at your office, Josh?
No, not currently.
Well, I make no money. I make no money if you were to go, research and take a Delphi or take a course with Johnny or Ben at Owens. It's just like really good material. I highly recommend you take their course. And I highly recommend you get a device. Now they're on their 3rd generation device, and they're doing some pretty cool stuff with it. So I'll give you kind of an insight. Like the Andrews Institute in Texas and in Florida, last time I spoke with them, which it's been a minute, but last time I spoke with Ben and Johnny at Owens Recovery, they were working on a ton of papers. Like I think before 2010, there was about maybe 400 papers published on BFR in the last decade, right? Which is not a lot, right? Like that's one treatment remedy over a decade. That's not that many. But from 2010 until 2020, in the next decade, there was something like 2,500 papers published on BFR. Some of them case reports, some of them, real big clinical trials. Needless to say, there are probably another 50 to 60 high tier clinical trials using BFR going on, like as we speak, right? One of them has the largest femur fracture trial going on, like within minutes, maybe not minutes, but like within a few hours of someone fracturing their femur, getting a tourniquet on. It's pretty remarkable what they're going to see when it comes to bone. Anyways, that's a little bit neither here nor there. They're using it for fall prevention. They're testing fall prevention in the elderly. They're checking, obviously, as someone ages and sarcopenia becomes a major issue, and bone density. They've got brittle bones because they're not moving, so therefore they fall? Is it they fall and so then therefore they stop moving? What's the chicken or the egg there? So they're using a lot of studies and a lot of resources to use BFR with the elderly as a method of fall prevention. And then one of my areas of interest is they're actually using BFR from the standpoint of neurological cases. So it'll be interesting to see what BFR can do from a neuro standpoint. And then Adrian Lau and a couple other pain science, experts or nerds, if you'd like, they're looking at the ramifications of BFR on the concept of pain, how some people can endure a lot during a BFR session and others the second that it gets grueling and tight, which I didn't mention early on, but the whole goal of putting a tourniquet on your leg is to reach muscle failure. So if you can do 50 to 75 reps, then we need to increase the resistance or increase some type of tension. If you do 15 reps and you're like, that's it, I can't do any more, that moment where you get to that muscle failure point, that's ultimately the goal. That's where we get a lot of that muscle protein synthesis. We get a ton of different enzymes and biochemical changes. Hormones are getting upregulated. So it's actually pretty cool to see that you can get significant changes and very little, if any, long-lasting soreness. So they've done a couple other studies to look at, how sore people get after a bout of blood flow restriction. Because if I took you to the gym, Josh, and I just said, hey, we're going to do the most brutal workout, right? Or I picture my buddy JC who did two Murphs on Memorial Day, and he did a third one the day before. So he did 3 Murphs in 24 hours, right? Like the dude tore tissue for sure, right? At 3 different gyms. So he was sore, right? Like if you go do something and you push your body to the limits, you will be sore, right? But what's interesting with BFR is you get all the benefits of heavy resistance training, all the benefits, and very little of the consequences of heavy lifting in the form of muscle soreness. Now, don't get me wrong, there are some eccentric exercises that will leave you shredded, like TRX rows, for example. If you're doing a bunch of TRX rows, like your bicep tendons will be really tender for a day or two if you've never done them, okay? But if you're looking for, squats, if you're looking at lunges, if you're looking at, hip abduction, if you're looking at, simple overhead pressing, you're not going to be super sore. And that's, in my opinion, one of the beauties of BFR is you get a lot of the strength changes and you don't get a lot of the soreness. The people that get sore are the ones that actually probably mismanaged a little bit of their own load and their own ability. But that's more clinical than it is, someone that's like user error. Like, don't be an idiot. There've been a few cases where people actually have gotten rhabdomyolysis from using BFR. And that's kind of what I was alluding to a minute ago. One guy went through a full workout and he was sick. He was on antibiotics, and then he got rhabdo, the next day. It's like, well, if you're sick enough to be on an antibiotic, maybe don't just go full tilt and just go, because antibiotics we know are trophic for certain tendons and whatnot. So I definitely think that he was tearing some tissue, and being on an antibiotic probably has more harm than the actual BFR. But that's just one guy's opinion. A couple other things were, one other guy developed rhabdo after he did arms. He had 2 tourniquets on each arm, and he went to failure on push-ups and a couple other exercises. Then he put the tourniquets on his both legs, and he went to failure. Then he did 4 tourniquets on everything, and then tried to do more things, and ended up developing rhabdo. So it's like, I don't know many people that have 4 tourniquets, so I don't think that's even possible. But the likelihood of that happening is so rare, and I think there's been less than 5 cases of rhabdo, and there's been, I don't know, tens of millions of applications of BFR in the last 10 to 12 years. So I think our odds are in our favor. Plus, if your clinical suspicion is saying this guy doesn't look healthy, this guy doesn't look well, I'm not putting a tourniquet on. If I just have that that sneaky suspicion that's like, this isn't going to be what does it. This person needs a different sort of healing or different sort of health conversation other than getting his quads blasted for 15 minutes. So use good judgment, as always. But no, I got a couple more questions. Josh, did you have any other questions?
No, just enjoying the content.
Oh, good. One of the things that happens either at every class or at like in the clinic, people ask really good questions. They ask like, well, what is this doing? Right. So I don't go through the background like I did with you a minute ago. I don't go through like, well, you have this one protein synthesis and it's called mTORC1. Oh, really? That stands for mammalian target of rapamycin complex 1. I don't say that, right? I'll say that to you because that's kind of cool. If you want to look up the gene, that's the gene. When that hydrogen ion gets elevated, that flicks on that muscle protein synthesis, which is also, the specific gene that's called mTORC1. Now, I don't say that to a patient. That's like, I don't need them to know the detail. So I try to keep it simple. Like, what is this doing? Well, it is, Mrs. Smith, good things happen when your leg is stressed out. However, you're not at a place where you can go do that yourself, right? Like you want to go run up a hill, you want to go, do a workout. If you think you're ready for that, great. Let's get you on the path to doing that on your own. However, if you can't do that, one of the best avenues for achieving strength and mobility and overall stability is getting our muscles a little bit stronger and using them. But if we don't use it, we lose it. Because muscle is very expensive, very expensive. So we want to save what we've got. So by putting this tourniquet on your leg, we're able to save the muscle that you've got, stress it out, and then it will build back even stronger. I almost gave like a little Biden quote there. It will build back better. I can't condone that. Okay. It's my company. I can say what I want here. We're not gonna be building back it, and so it's one of those things where you just got to let them know, if we can, then we will. If we can work out, then we will. If you can go ride a bike, go ride a bike. If you can lift heavy, go lift heavy. If you can do a CrossFit exercise or CrossFit workout, go do it. If you can't, do this. This is a good strategy. It's going to be tough. Your leg's going to be stressed out temporarily, right? And the second that cuff deflates, you'll have earned it. Right? It's not one of those things where you'll hate me for it. You're going to feel a difference like within just a few minutes. And that's probably another takeaway for me is I think I got tired of adjusting patients and them feeling temporary relief where they'd be like, yeah, I felt really good. But then by the time I got to the car, my neck still feels really bad. Or my headache came right back, within the next like 3 to 6 hours, it just came back. And I'm like, man, I don't like the feeling of temporary relief. I like the idea of maybe temporary suffering for long-term relief. And I'm willing to endure just about anything if it means that in the long run, I overcome what I'm currently suffering with. But not many people think that way. So we also have to convince our patients that this is a step on the process, which is a component of your recovery journey. It's not going to be your muscle is not going to go from like, and the picture I showed you, it's not going to go from like week 1, it looks like real atrophic and you can clearly tell which knee had the surgery, to week 4, just because we say so, or just because we want it to be. No, like that dude worked for 4 weeks straight and he got what he wanted, which is a quad that looks the part, looks like a professional football player's quads. So I think our patients need to see the evidence of it. They need to see proof in the pudding, which is why I show them that picture as well. So there are some components of like, this is going to suck. And I'm right here. I won't do anything irresponsible. We're going to get to 75, right? You might get 75 today. You might not. So be it. We'll aim for 75 tomorrow or Tuesday or Wednesday, whenever you come back. But here's the goal. The goal is to actually get you strong enough that you don't need this. The goal is to get you off of this tourniquet and into your own workouts, right? So we're going to use this during the moments that you can't load the limb because it currently hurts. It's great for clinical applications like knee pain, where people just have this vague going up and down knee pain, going up and down stairs. they get this vague knee pain, and you're like, it's not a meniscus, it's not patellar tendinopathy, it's just like, I don't know, it's just knee pain. Like, I don't know what else to tell you. Doing some BFR with the legs goes a long way to help strengthen those quads and help unload the knee joints. That's all I say. I try to keep it simple. Just keep them strong. I forget which paper it is, but it's like 1 to 2% quad strength improvements reduce one's likelihood of developing osteoarthritis of the knee like 100-fold. Like it's not a small amount. It's like 100-fold. So getting our patients quad strength, if they come in with knee or hip or ankle discomfort, and we just focus on the quads to try to get them that 1 to 2% improvement on overall strength. Like for me, that's just a done deal. Like we're going to do that for sure. Cause like their long-term goals, require that we address what's going on with the quads. So, but that's a little clinical gem that I've got for you there. So Josh, any closing questions, closing comments? I'm trying to think if I can see any here. Oh yeah, here's one question. How does it affect the proximal muscle? And as I mentioned earlier, if I put the tourniquet here, but the rotator cuff obviously is more proximal, right? And even if I'm doing push-ups, this is probably a better example, right? The lateral pectoral artery supplies pec major. Okay. There's a nice anatomy review for you there. But the lateral pectoral artery, it is proximal to the cuff because the cuff is already basically into the armpit, right? It's on the upper arm. So that artery is already, detached off of the main branch in basically like, just above the clavicle here. So the lateral pectoral artery is proximal. So how do push-ups get stressed when incorporating BFR? So here's the beauty of how this works. So let's say I have a pec strain, or let's say I just want to work on overall pec strengthening. Okay. So as I go into my push-up, right, I will utilize all of the oxygen in my proximal muscle and my big muscles first. So that will be my pec, maybe some of my deltoid, right? And hopefully not too much of the upper trap, but like this whole area, I will use a lot of the oxygen as quickly as possible. And that will actually be slower because it's proximal. Let me back up. That will be proximal, and that will be a slow oxygen diminishment. But below the cuff are where my synergists will be. So we have my bicep and my tricep, and they'll be below. Now, nothing is more excruciating with BFR. Well, I shouldn't be dramatic. At least it is for me. But when your synergists get depleted of their energy reserves, so if I have the cuff here and I start repping out push-ups and I use up all the oxygen in my bicep and my tricep, what then am I going to predominantly use to fulfill the push-up? And the correct answer is, well, the pec, right? So I have never been so sore in my pec after doing BFR push-ups, right? My arms, not too bad, right? But the fact that as I go down, now I'm getting all sorts of strain and stress, and then I come back up for the push-up, I am like, it just shreds me. And I feel it, go figure, where you should feel it for a push-up. I feel it isolated in my pec, right? If I'm doing upper, I feel it in the upper pec, lower, I feel it in the lower pec. But most of the time when I don't use the BFR for my push-ups, my triceps dominate. My triceps and my delts are incredibly sore after doing push-ups. And so this helps to just reinforce the function that I want out of my push-ups and out of the muscles that I'm trying to rehab or recover from. So that's called the proximal effect. There's also another concept called the backflow, which means if the tourniquet is here, well, then all the blood's going to backflow this way, right? So I'm going to have like not a pooling, but just, like if it rains on the roof and there's a stick in the gutter, water still comes out the spout at the bottom, but it just stuck up on the roof for a little bit, and rain starts to pool on the roof before it comes down. The same thing happens in the arm and the leg, and it's perfectly normal. It's fine, and it actually has a really good muscle activation component to it. So we actually can see an increase in surface EMG over the areas where we have this backflow effect going on. So those are some of the physiology, pathomechanics of it. I'm trying to cram as much as I can into just 1 hour. If you're really interested in it and how it's useful in clinical practice, I highly recommend you take a course. It is incredibly safe. It is also very profound in the results that it gets. And again, the quality of the device does matter. I don't think you'll see as significant of strength gains with any other device other than the Delphi device. But I will say I need to test the latest smart cuffs and a couple of the other ones out there, because it's been a few years since I've looked at them. Good questions that came in. I appreciate the questions. I think that's it. I think that's all I've got written down. Let me know how you guys like this. Those of you that are watching the replay, those of you that purchased my birthday bundle, let me know. Thank you, by the way, from the bottom of my heart. Thank you for doing that. Let me know your thoughts on the clinical side of the cohort. I want to make sure that you guys are getting as much value out of this as possible. And again, I'm a student of Alex Hormozi, so his methodology of give some more, and then they'll ask. This is me giving. I just want to give as much of the resources and knowledge that people have gifted me or given to me over the years. I want to make sure I can share that with you guys. That's the point of these calls. So shoot me a message if you have any key takeaways from today's call. Josh, any key takeaways for today?
No, I just think that this definitely would have a good application, with a certain demographic of my patients. And like you said, with like the delayed onset muscle soreness, a lot of people complain about that when they're just starting to get into trying to do some strength training or whatever. But it's interesting that you're not as sore with this type of treatment.
Yeah, and if they are really sore, I almost always try to reframe it as a good thing, right? Like, oh, good, that's awesome. That means we worked it. This is good. Like that muscle's alive now. You kind of, because that this is a good thing for them. This is not anything you've done to them. This is something that you've worked them through for them, right? And keeping the big picture in mind. I do warn them though, if we do any eccentrics or anything, like you're gonna be kind of sore. But if you're just doing, this sort of thing, like the most soreness you feel is while the cuff is on, and then as soon as it's deflated, give it a minute and they go again. Like that's really the beauty of it. So, okay.
All right.
Excellent. Thank you, Josh, for being on here. And like I said, thank you to everyone who are going to be watching the replay over the next couple of days. If you have any tips or any suggestions for something clinical that you're wrestling with, feel free to send it my way, and we will certainly set time aside to talk about it moving forward. I think we've got a couple of good weeks planned in the works here, so feel free to keep an eye out for subsequent emails. And I appreciate keeping an eye out for this week's Midwest Monday. That'll be sent out early Monday morning. I appreciate you guys. I'll let you get back to work, Josh, and appreciate it. If you need anything, just shoot me a text or shoot me an email. And other than that, I will see you guys 1 week from today at the same time. Thank you.
All right. Thanks. See you.
Bye-bye.